Hi guys, my name is Sanjay Gupta. I'm a consultant cardiologist in York, and today I wanted to talk to you about atrial fibrillation and in particular about warfarin. Um, the first thing to say is that, as you know, people who have atrial fibrillation require anticoagulation because there is a substantial risk of stroke. And by anticoagulating the patient well, you reduce the risk of stroke by about 64%. Okay. In the old days, people used to give aspirin. Aspirin has no role whatsoever any longer. So the choice lies between warfarin and the newer agents, which are called the NOACs. Now, until very recently, the only choice most people had was warfarin. Now you have these new agents. The new agents have substantial advantages. The biggest advantage is that they don't require the monitoring associated with warfarin. For patients who take warfarin, they require frequent blood tests because the dosage of warfarin is adjusted according to the blood test called the INR. Okay, INR is International Normalized Ratio. So that's a blood test. The way warfarin is given is that it's initially prescribed, and then you have to have a blood test, the INR, and based on that INR, you know whether the anticoagulant effect is optimal or not. You need to get the INR between 2 and 3, and if you don't get it between 2 and 3, you're essentially not getting the benefit of the warfarin, and the dose has to be adjusted accordingly. And this is a real hassle for most patients because it necessitates recurrent blood tests, recurrent travel to hospitals or GP surgeries. In addition, there are substantial other advantages of taking the NOACs. I've explained them in my previous videos, in particular the fact that NOACs are associated with less intracranial bleeding, substantially less intracranial bleeding than warfarin. They have very few interactions, whereas warfarin has lots of other interactions. And on the whole, most doctors, if they had atrial fibrillation, would prefer to be on a NOAC. The problem is there is a reluctance to prescribe NOACs because of the perceived cost associated with prescribing NOACs. For most people, if most primary care physicians feel that warfarin costs a few pence, whereas the NOACs cost a lot more money. Okay, so a typical month supply of a NOAC, I can tell you exactly the values. But a month's supply of, let me just tell you this because I've got it written down somewhere. A month's supply of apixaban, 5 milligrams twice a day, is about £68. A month's supply of dabigatran is about £57, and a month's supply of rivaroxaban is about £70. So that is substantially more than taking warfarin, which costs only a few pence. And therefore, there's a real reluctance in primary care to prescribe NOACs. Now, most GPs are very well-meaning. They want to prescribe these agents for their patients, but then there are these other political bodies, commissioning groups, who then hold the purse strings to the budget, and there is a little bit of reluctance on their part to open the floodgates to the prescription of NOACs. So I was very intrigued by this because I really felt that actually it wasn't as straightforward as that, although warfarin itself costed only a few pence, the real cost of warfarinizing a patient is probably much more. And I wanted to look into this. So what I did was I did a little study. Now, this is not published. It's an audit. So it's a retrospective thing. It's not published anywhere, but I have the data to hand. And if anyone asks me for the data, I'd be happy to show it to them. But what I did was I took 50 patients who had been diagnosed with atrial fibrillation and they needed cardioversion. So generally, when people come to us with atrial fibrillation, and if they're symptomatic, we think, oh, well, we need to see if we can shock them out of the atrial fibrillation. The problem with shocking patients out of atrial fibrillation is that you are then attempting to restore normal heart rhythm. And in doing so, you could potentially dislodge a clot that may have formed within the heart during the patient being in atrial fibrillation. So it is generally recommended the patient has anticoagulants for about a month, or the patient is optimally anticoagulated for about a month before you attempt to shock them out of that heart rhythm, out of the atrial fibrillation into sinus rhythm. Otherwise, you predispose them to a higher risk of stroke. So when we get patients who come to us with atrial fibrillation, first, presentation of atrial fibrillation, or they've been picked up as having atrial fibrillation by their GP, they're sent to us, we look at them and we think, okay, let's try and shock you out in the hope that we will get rid of the atrial fibrillation, at least for a short amount of time for you, and you'll feel better. So we would normally say, well, now you need to go on an anticoagulant, okay? And after a month of being on optimal anticoagulation, we'll bring you back and deliver a small shock to the heart. So I looked at 50 such patients, okay? And what I was really interested in knowing was, the first thing I was interested in knowing is that once we make that decision, how long does it take for the patient to actually go on warfarin? And what I found was that on average, it took about 10 days for the patient to start on their first tablet of warfarin, okay? That's just their first tablet of warfarin. Remember, they're not anticoagulated optimally when they take their first dose. They're only anticoagulated optimally after they've taken warfarin for a while and their INR has consistently found to be between 2 and 3. So I found that on average, 10 days were spent just taking your first dose of warfarin. So you see the consultant in the cardiology clinic, and it takes about 10 days to get your first tablet of warfarin. So 10 days of being unprotected. Okay, that may not be a very big number because on the whole, the stroke risk is substantial over a number of years, but not huge over just a few days. But then the next question was, okay, so once they've started the warfarin, how long does it take for that patient to be optimally anticoagulated? Okay, i.e., how many days does it take from starting the warfarin to getting your INR consistently between 2 and 3? And I calculated this time, and I found that on average it took about 35 days for patients to start taking the first tablet to being optimally anticoagulated. So that takes you up to 35 days plus 10 days that you've waited before just to get optimally anticoagulated. And after that, you have to wait a further month before you can have your cardioversion. Okay, so 35 plus 10, 45 days of not being protected. 35 of those days you're taking the warfarin, but you're not getting any real benefit in terms of stroke prevention from it. The next question I was interested in asking was, how many blood tests on average does a patient need before they can be consistently anticoagulated, before their INR reaches 2 to 3? And on average, we found that patients needed 11 separate INRs, 11 different blood tests, 11 visits to have a blood test before they reach that point where they could be considered optimally anticoagulated. Okay, and so when you compare that to a NOAC, well, a NOAC you can take straight away. Okay, so there's no delay, there's no long wait. Because whereas warfarin is instituted in most places in a warfarin clinic, NOACs can just be given as a prescription, so you can just pick one from pharmacy and start taking it. And the second thing to say is the NOAC starts working almost immediately. It works within 3 or 4 hours. So the day you start taking the NOAC, you're anticoagulated. The other thing to say about the NOAC is you don't need these 11 blood tests to know you're going to be anticoagulated. So you get your anticoagulation straight away, and you don't need these blood tests. Okay, and so from the day you start the NOAC, you can be pretty confident that if once you've completed 4 weeks, you can go and have a cardioversion, provided you're taking your NOAC religiously. You can have your cardioversion within a 4-week period. With warfarin, what happens is you have to wait for at least around about 35 days just to get it within range. And then you have to wait for another 4 weeks to try and keep it within range before you can have your cardioversion. So you automatically double the time you're waiting to have your cardioversion, but you're actually exposed to the risk of strokes for half that time. Okay, so that's important. And then the most important issue for me was to work out, is it really cost effective, this waiting, etc. Now, I went and I tried to do some research, and the cost of an INR, just the cost of a blood test, is about £5. The cost of an INR and having staff to advise you on changing the dosages, etc., the cost of running an anticoagulation service, which is what most hospitals have, amounts to £16 per blood test, because they count the £5 for the blood test itself, and then £11 for paying the staff, the phone calls, all that kind of stuff. So each blood test amounts to about £16. Now, if you think of it and you multiply 16 by 11 blood tests, okay, which is what most people have to have before they can have their cardioversion, that works out at £176. I think it does, yeah, £176. Whereas the cost of just taking a month's supply of apixaban is £68. And dabigatran is £57, and rivaroxaban is £70. So although doctors may say, primary care physicians may say, well, warfarin is cheap, actually the cost of warfarinization is much more than just the cost of the tablets itself. And therefore, it's a no-brainer to me to be on a medication which works very quickly, i.e. keeps you safe, B, allows you to go and have your cardioversion much sooner, doesn't put you through the inconvenience and the indignity of having recurrent blood tests, and finally, actually works out to be cheaper. Now, of course, it may be different for people who need to be on anticoagulants long term, and this is where some of these arguments may be right, but truthfully, I think that there's a bigger risk leaving people unanticoagulated or under anticoagulated for a long period of time, because actually, if you're unfortunate enough to have a stroke, then the annual risks of having a stroke are around about £11,000, which basically blows this whole argument that warfarin is much cheaper out of the equation. So I hope this was useful, and it may allow some people to be able to convince their doctors to give them NOACs. I certainly know I would want a NOAC for myself if I had atrial fibrillation, and I would certainly want it for my loved ones. And if as a specialist who sees this all the time, if I think it's good enough for me, then I think they're good enough for you. All right, so I hope this was helpful. Now, let me just give you some information, the usual. So my name is Sanjay Gupta. I'm a consultant cardiologist. This is my website, yourcardiology.co.uk. And this is my Facebook page. So thank you so much for watching. I love all this great feedback that you send me. It keeps me motivated. I want to do more videos. I'm going to keep trying to do more videos. So if you have any questions, don't hesitate. Drop me a line and I'll try and answer them in the next video. Thanks so much. Bye.